struggle at that point. I didn't want to teach it at the end of this lecture because then you will lose your concentration also. So I'll be starting with developmental assessment and then move on to abdominal examination and then central nervous system examination, right? Uh, so the technique of examination I'm not going to discuss. You can nowadays lots of videos are available. Even in YouTube you can find MR CPCH videos and um, videos published by Colombo Medical Faculty. They all are good. What is needed is you to practice. No point just watching videos without doing it in practical setup, right? You can do all these examination in your hostels, so you can um, use your colleagues as patients and vice versa. That's how we did. So developmental assessment. So this is what exactly you have in your illustrated pediatric books. These 4 pages are extremely important. I don't mind even if you take snapshots of these four pages in your phone, and because phone is the one which you use to refer most of the time. So just have a pictorial memory of these 4 photographs, 4 pages. Out of these 4, what is mainly important is fine motor and gross motor development, because speech development we are not going to assess in the exam. Social behavior is the third important one, right? So in general, we tend to give you all patients above 6 months, below 12 months, right? That is the chronological age. But different milestones will have different developmental ages. So the chronological age of a 10-month-old baby will have social development about 11 months sometimes, but the gross motor development may be around 8 months. So in your exam, what is expected is for you all to give the relevant developmental milestone of each domain. And at the end, you can say in overall, I think this child's overall development is like that, right? So you can see newborn limbs are flexed, symmetric. This age you won't give. I mean, this age babies. In that case, we might ask you to do neonatal examination. If I have a time, I will just give a brief introduction to that. But I don't think you will get it frequently nowadays. And 6 to 8 weeks, if you keep in prone position, just raising head, this is the most important photograph. 6 to 8 months. See how this baby is sitting on the bed. So sit without support at 6 months with round back. So round back means there's a thing called tripod position, in which babies keep their hands in front. So then it makes as a triangle like, right? And 8 months straight back. This is the key for you all at the exam, this photograph. Because crawling will not be assessed at the exam. Walking around furniture is bit difficult to assess, but on the bed sometimes we might ask mom to try to walk the child on the bed holding the rail. Walking independently we are not going to assess in your level of exam, but in postgraduates we never give children less than 12 months. In postgraduates, walking steadily is 50 months. So keep an idea like, okay, we will be giving, but we can give you about 12, 13, 14 months of babies as well. It's not important to give the exact age because it's not possible. You can give a range but obviously you can't give a range of 6 months like. So I think this child's development is 6 to 12 months. Anyone can say that, right? So we expect you all to give a range minimum 3 months like, not 3 months after. I mean, after 1 year, 3 months is allowed, but before 1 year, we want 2 months gap. I think it's 9 to 10 months of age, likewise, right? So you can go through these leisurely, but look at fine motor. Most important thing is this 6 months thing. And 4 months also you can comment at the exam. 6 months they can grasp and transfer, and when you give two cubes, they can bang them together at around 7 months. And the one who can do that, the next thing would be for you all to give a small bead, which you all bring at the exam, but you will never bring when you do appointments. So to check pins across. And then the next thing beyond this, those who can do this, you have two options, that is a crayon or a book. So what I'm going to teach you is, what are you going to use at the exam? You have lots of things in your basket. You don't know which one to use, which one to select first. I think in 99% of the cases, all of you all will have to use same sets of equipment or paraphernalia for the developmental assessment in a sequential order, right? Uh, and social behavioral wise, I would say put food in mouth and wave bye-bye are most important for your exam. Now be confident to do this station. Don't make faces when you were asked to do developmental assessment. I can see sometimes you all are not that ready to do this. Oh, but I can assure that most of you all will not kind of get very low scores here, because even if you just observe and give your comments on the child, majority of you will get more than 30%, not like other exams. So this is an exam which you can uh, pass very easily. So I have put social, emotional, behavioral development as the third component rather than speech, hearing, language, because I don't think we can objectively do these things in exam, like these distraction test like thing. We don't expect you all to do, but with your general observation, sometimes you can say, okay, while you were distracting the child, while you were performing your task with the child, if there's a bell or something which rang, and if the child turns his head, you can just give a vague comment, okay, during my examination I found that though child was concentrating on my task, he turned his head to a loud noise which suggests to you that his hearing seems to be all right, right? That kind of a comment. So these 4 pages are more than enough. Don't look at any other books. No need any other thing for this assessment. Take photographs of these 4 pages and keep it in your phone and refer it, see it frequently, right? So how to approach? So you will be asked to do the developmental assessment. So the first thing is observe for a while. So why I say while is, you can't just stand in front of the child just observing, right? So there's no difference of the candidate versus examiner in that case. Now while observing, you have to think, okay, what am I going to do now, like? So we will never give a child who's sleeping on the bed for the developmental assessment. Most of the time we will be giving a case that the child will be sitting on the bed playing with some toys and playing with mom, that kind of a thing. So think, what are you going to do next? So it's not nice to start with very kind of, you know, so if you can see child is sitting on the bed, that means, you know, definitely head control is there. And if it is arch back, you know, this is somewhere around 6 months. If it is straight back, you know, this is somewhere around 8 months. So start with something which is compatible with 8 months. But having said that, that is only the gross motor which you can observe. So their fine motor may be totally different, right? So keep that also in your mind. But if child is already playing with toys, that means child could take or grab toys and transferring toys, that kind of things you might be able to observe. Now you will have to alter your order based on the response of the child, right? Now don't think that you are going to do gross motor first, fine motor second, social behavioral third. There's nothing like that in the assessment. But when it comes to presentation, it's very important to present your findings in that order. Now, speech is something which you will not be able to assess during your examination, but you might be fortunate enough to hear certain noises, right? In that case, it's always better to comment. And you can always ask mother's help. Mother, would you be able to take the child or lift the child up for me, right? ඇදේ වාඩි වෙලා ඉන්න එකෙන් පොඩක් උස්සන්න පුළුවන්, right? Because rather than you trying to do these things, child will be more familiar with mom, and that will help you to continue with your examination. Otherwise child will start to cry. Now this is the commonest scenario. I'm telling you, this is the commonest scenario. Be prepared for this to get a distinction mark. So child who is sitting on the bed doing something. I didn't want to use any other photographs. I wanted you all to familiar with your own book, right? That's why I use this. Okay, now what you can see, okay, child has got definite head control. Child is on seated position. You don't know how this child came into this, whether mom assisted to sit or not. That's not a problem, but somehow child could sit on the bed with the straight back, means somewhere around 8 months. So now your task will be to assess the development, right? This child maybe even 15 months, maybe still 8 months. So you don't know. So what are you going to do? So we know this is definitely more than 6 months. If straight back, okay, we know definitely this is 8 months. Now the best thing is, don't try to lift the child up and ask to walk around furniture. Never ever do that. Please start with fine motor development. Now what are you going to give? Now in this photograph, child is already holding cubes. If not, your first thing has to be give small cube, 1 inch each. You know the size of a cube, right? Now what you have to do is, you give a cube. If child is reaching for that cube, you know fine motor development is more than 4 months. If child could grab that cube, okay, you know child's development age is now 6 months. If child is transferring that cube into the other hand, okay, you know 6 months plus. And then what you have to do is, you take another 2 cubes and just demonstrate like banging, right? Now I hope you can imagine I don't have cubes here with me, and give another cube to the child for him to do that same thing. If he does banging, so that means it's 7 months, right? Now you used only few cubes taken out from your uh, pocket, right? Then, okay, now child will be somewhat familiar with you, right? For before you do the next task, please take all the things what you have given up to now. So otherwise, child with object permanence, that means which develops around 9 months, will be looking for the things he was given before, right? So he'll be looking for these cubes again and again. He will not be receptive for you to go ahead with your next steps of the examination. Now we know if the child could bang like this, now it's 7 months plus, then our task would be to see the pincer grasp. For that, you can give a small beat. So the first thing is cube, second thing is small beat, right? Do all these things competently rather than just uh, right just wondering like what to do, and right, don't show you immaturity. Okay, you just show the examiner that you have a plan, right? So there are different ways of assessing this pincer grasp, right? So some towards around 7 months, like they try to grab it. Now I will show you, right? So when you keep it like this, so around 7 months they try to take it like this, right? And around 8 months they try to take it like this. So the very mature pincer grasp is like this, right? This is beyond 8 months, right? If with the great difficulty they are taking probably around 7-8 months. If somewhat maturity, it's around 9 months, but full mature pincer grasp around 10 months. Now those who have read different books, those who are very keen on learning, who have read different books, will have different age groups for this pincer grasp. So that's why I'm telling read one book 100 times rather than 100 books one time, right? So we follow what is given in illustrated pediatrics, right? So that's it. So the first thing is cube. With that, you could assess reaching for objects, grasping for objects, transferring for objects, and then banging. If banging is also there around 7 months plus, and then you give USS pincer grasp. Right. Up to now, you have not touched any gross motor thing. Okay, now pincer grasp is there, it's more than 9 months. Now, if pincer grasp is there, the next thing would be to give a book or a crayon. In illustrated, it says crayon, but I would advise you to give a book. Book means pages should not be thin like this. You know, small story books which have probably around 10 pages, which they could turn pages. So if they can turn pages, several pages at a time, so then the development is around 12 months. But if they can turn pages one at a time, this will be your MCQs. That is 18 months, right? Or then if they can do that also, then the crayon. So We don't know. In your exam, sometimes children might be there who could hold a crayon, right? So, so for fine motor development, only 3 or 4 things. One is cube, second one is a bead, third one is book, fourth one is crayon. Crayon carry pastel, right? Right. At the same time, you could do, now you are dealing with these small gadgets, right? At the same time, you can look for object permanence. That means you could, now you have used either crayon or with book it's a bit difficult, or bead or a cube. You can just hide under a bed sheet, right? And see whether child is looking for it. That is what is called object permanence. That means that child is particular on that object. So this is what we call peekaboo as well. So that it's a bit different, but with that you can just check bit of a social development. If child is looking for that, that is object permanence is there. Okay, now at the end of all these things, now come back to gross motor. Now child is on sitting position, you can pull to stand, or you can ask mom to do that, and then you go back to the end, foot end of the bed, and encourage the child to cruise around furniture, right? So that is so they will be able to do this if they are more than 10 months, right? Usually we don't expect you to take the child out of the bed and ask to walk on the floor. Especially in these circumstances, we will not ask that, right? Now you know, okay, that is the end. The child could cruise or walk around the furniture, but no independent walking. So that will be the commonest scenario. Now you need to end the station. For that, you can say bye-bye. So that's another social development which you are going to assist. So that will be your completion of examination. This will take only about 3-4 minutes, nothing much. And you can observe some speech and language development during your examination. So when I am examiner, I used to ask, okay, you can ask 1 or 2 questions from mom about the speech development if child did not show any vocalizations, right? If the examiner did not ask that, don't try to do that. So how are you going to present? Always present 4 domains separately. Now, though you assessed domains together, present it separately. You can comment on speech if you hear any. If not, you can say, I could not comment on speech, hearing, and language development because I did not hear any vocalizations during my limited examination or during this short period of examination. Just say what you have observed and demonstrated only. Child's aid may be different. So different candidates might have given different ages for the same developmental milestone. Case, it's not a problem because what we want is what the candidate has elicited during that short period of time, right? Don't go out and compare, okay, what was your developmental age? Oh, I said 9 months. Oh, I said 11 months. Oh my God, right? Don't. Now that is not something you need to do because It all depends on the amount of milestones particular candidate could elicit. And also, do not look at the child while presenting your findings. This is applicable for all cases, right? Presentation is something you have already done your observations. Don't observe again. You can give a range of development. So this is how you are going to present. So I performed a developmental assessment of this boy who was very cooperative and cheerful during my examination. So this, now in developmental assessment, you don't need to say, I examined this child. That's wrong statement. I performed or I took developmental assessment, or I did a developmental assessment of this boy. Now lying comfortably on the bed and age appropriately grown, it's a silly statement here. So in this case, it has to be how alert, active, friendly the child is like. Who was very cooperative and cheerful during my examination. And in abroad, what they will say is, I perform a developmental assessment of this lovely young lad. Those are the terms they use. And who was very cooperative and cheerful during my examination. So he could sit without support with a straight back, and when I pulled to stand, he could stand. He could do that. Though he could cruise on the bed holding the rail, he could not walk independently. Therefore, I think his gross motor development is around, you can say, maybe 10 to 11 months. With regards to fine motor development, he could transfer objects from one hand to the other and could bang two cubes together. He had inferior pincer grasp. So inferior pincer grasp means not that mature. He could not turn pages in a book. Therefore, I think his fine motor age is around 10 months. Always better. It's important to have a milestone which he could not perform. That is the age mark. You're going to say, okay, this child is not beyond that level, but beyond the level of that. So in between. So he did not have stranger anxiety, which is compatible with less than 9 months. That's why child was very cooperative with you during your examination. If not, that means child, so you knew child to you like, it's very unlikely. But he has got object permanence and he could wave bye-bye. I could notice some polysyllable babbling sounds during my examination. Overall, I think his developmental age is around 9 to 10 months. That's it. So then we might ask certain questions. Okay, do you think this child has got hand dominance or not? So when do children get hand dominance? Anyone? Those who do not want to speak, you can even send a chat message. At which age children get hand dominance? Oh, I can't see anything. So it's around 18 months. Any hand dominance before 18 months is a sign of weakness of the other hand. However, in the exam, we will give you children who have cannulas. Right? In that case, dominance of that hand will be automatically reduced. Right? So the child will be using the other hand mainly because he can't mobilize fully the hand with the cannula. Right? Right. Okay, clear? Any questions on developmental assessment? It's better if you can talk because I don't know whether you are sleeping. Any questions on developmental assessment? right? Don't think much. Just keep an idea. Okay, cue, beads, book, crayon, and reaching for objects, banging objects, hiding objects. Then walking around furniture. I'm pretty sure no one will be able to. So if the child can walk independently on the bed, so the next task will be to assess whether the child could run, but you're not going to do that at the exam. So you can say, okay, it's 12 months plus. So you will be marked mainly on the way you conduct the examination, assessment rather, plus the way you present. Okay, let's move into abdominal examination. Now I need to rush this, otherwise same thing will happen today also. So abdominal examination is the easiest examination to perform, but the most difficult examination to give differential diagnosis, right? So the easiest examination to perform, but the most difficult examination to give differential diagnosis. So be prepared. So all these preparations can be done at home rather than thinking of causes of isolated hepatomegaly at the exam. All the things could have been done at home, right? You can't analyze. Okay, hepatosplenomegaly with anemia. You can't always analyze at the exam. At least keep one or two differential diagnoses in your basket. Okay, so components of abdominal examination comes general examination, abdominal examination, and genitalia examination. So the abdominal examination can be divided into four components like inspection, palpation, percussion, auscultation. So I have frequently encountered you all don't auscultate in abdominal examinations and you don't palpate in cardiovascular system examinations. So, so most of these examinations you need all four components. Unless we ask you all to do that, do not try to examine genitalia. But if you see a inguinal herniatomy like scar in a child, always offer or ask the examiner that scar may be a case of orchidectomy or orchidopexy scar. So in that case to palpate testicles in scrotum. Otherwise you don't need. So before everything you need to know what are the common cases that you are going to get at the exam. If it is a less than 6 months, highly likely a case of biliary atresia plus or minus Kasai procedure. Right? Number two, thalassemia is the commonest. Some of these patients you would have seen, but still you perform very badly. Right? Because now sometimes those who have seen these patients find it more difficult sometimes. You can't remember whether this child has got splenomegaly or hepatomegaly both, or only one, or at that time what you are thinking that rather than concentrating on the present physical signs. Portal hypertension is a very common case which we bring to the exam specifically, because these children will be at home who have isolated splenomegaly. It's very easy to find these children and give a call and bring it to the exam. Hereditary spherocytosis are also like that. They will usually have a little bit of jaundice, anemia, and splenomegaly. IMN can come at any exam, even in medicine. And also children with nephrotic syndrome will have certain abdominal signs. So we will give that. Sometimes very thin children can have, you will be able to palpate fecal masses. So that is also something we can give. Any other lumps, like in surgical exams, you will get lumps. In your Ginenob's exam, you can get a lump arising from the pelvis. So these kind of things are a bit rare in children, right? Don't try to cook physical signs and say, okay, there's a mass here and here, right? Think with what is the case you are going to, is it hepatomegaly, splenomegaly, palatable masses, or fecal masses wise. Then we can think about differentials. So general examination, palo is very important. Cyanosis is not important here. But cyanosis can be important, like conditions like hepatopulmonary syndrome can give rise to cyanosis, but at your level, focus mainly on palo. Jaundice is very important, could be due to anything, hemolysis or hepatitis, or I mean liver pathology. Uh, Fever, it's important, like in hepatitis, cholecystitis, malignancy, IMN. Lymphadenopathy is a feature of malignancy and IMA, because malignancy might not come in your exam, but as a differential diagnosis, you should mention it. Features of chronic liver disease, palm erythema, flapping tremors. These are bit rare. I would say bit rare. And periorbital edema, because in nephrotic cases, you can get in general examination ankle edema, suggestive of low albumin or feature of chronic liver disease. These are the general examination things. So in your presentation, you will have to say, okay, this child has not got any jaundice, palo, fever, lymphadenopathy, or any features of chronic liver disease. Like now, this has been a problem. When it comes to abdominal examination, you have to be very gentle, very gentle. Just palpate very softly, synchronized with the child's breathing. Don't try to push the abdomen when the child is exhaling. That means child is trying to expirate. So during expiration, don't try to push it, right? You can lift up your hand when the child is expirating. In inspiration, advance it gradually upwards. Now we can definitely identify those who have not done abdominal examinations adequately at the exam, because you tend to push like this. In adults, you can do that because they have large fat mass, but in children, you can't do that because it's they are very thin. And it's very important to look at the face of the child while palpating abdomen. Don't look at the examiner, don't look at elsewhere, just look at the face. Now you can distract the child during the exam by talking to the child. තාගේ නම මොකක්ද, බත් කෑවද, ගෙදර බල්ලෙක් ඉන්නවද, පූසෙක් ඉන්නවද, කාටුන් බලනවද. So likewise, get involved the child, right? You are not going to ask the diagnosis from the child, but you can have a chat with the child, right? And do not forget to percuss the upper border of the liver. This is something I would say at least 50% of candidates will not do this. And also, you tend to forget auscultation of the abdomen. And ask the examiner whether to proceed with genitalia examination or anal examination, digital rectal examination, right? Right. So abdominal inspection is very important. No point just looking at the abdomen without commenting to yourself, okay, what I'm looking at now. Okay, abdomen whether it's flat, distended or scaphoid, hardly any value, but if it is distended, it could be due to anything. Surgical scars are very important. Because of that, do not miss inguinal surgical scars. For that, you will have to have adequate exposure. Ideally, it says up to the mid thigh, but we don't recommend you to do it at the exam. But do not expose genitalia, but you can still look for the surgical inguinal surgical scar. Right? Common surgeries in children. Splenectomy is very common in thalassemics. Kasai procedure is common among biliary atresia. Perioperative cholangiography scar is almost at the exact place of biliary tract and the liver, but the scar is small. Liver biopsy scar is the smallest scar. Don't miss that. Right? So, an orchidopexy and inguinal herniatomy scars will be there in inguinal canal. And explorative laparotomy scar will be in the middle. And appendicectomy scar would be McBurney's incision line. Oh, sorry, Lance incision, McBurney's point. Right? It's nice to know the name of these surgical scar like rooftop incision, groin incision, Lance incision, right? But pediatricians might not know the exact name of the surgical scar, but if you can confidently say that, we will agree whatever the incision you are going to tell. Examine the surroundings, especially look for pale stools and dark urine in a case of small infant with jaundice, right? Okay. Now these are the things you are going to find. Either hepatomegaly, right? Either splenomegaly, either palatable masses. Very rarely you might get palpable bladder as well. Some children towards the end of the abdominal examination will get palpable bladder due to they had no chance to go to the toilet. But that is not something we expect you to mention. But if it is there, you can say fecal masses. Most of the times, these things can be accompanied with certain general examination findings. Now, how to give differential diagnosis? This is very important. Now, I will do an animation for this, otherwise you will not concentrate on. Okay, isolated hepatomegaly. That's isolated hepatomegaly, no palo, no jaundice, no fever. This is a common scenario with a huge liver, but nothing else. So no palo, maybe you would have not appreciated also sometimes. No jaundice, no fever. So in that case, three differential diagnoses. Even as a medical student, I had these three differential diagnoses in my basket. So GST, congenital hepatic fibrosis, hepatoblastoma, right? But it may be a case of something else. Even sometimes Wilson disease can have. But GSTs will not have any palo, no GSTs means glycogen storage disorders. So there are other storage disorders as well. In addition to glycogen storage disorders, you can mention that also. But no harm even if you memorize these three rather than trying to work out at the exam. Right. Now you have a case of hepatomegaly and jaundice, but no fellow fever. So markedly hepatomegaly and jaundice. So in that case, infectious hepatitis, it could be hepatitis A, hepatitis B, and Wilson's disease, right? Then isolated splenomegaly. Isolated splenomegaly without hepatomegaly is, unless proven otherwise, portal hypertension. That's very common. Now, when you come to exam, you tend to give diagnoses which are there in your textbooks. Be, I mean, tailor-made into your situation, or customize these differential diagnosis into your particular patient. Now, never ever come and say malaria, Khalasa, IMN to a huge splenomegaly. So don't mention that kind of diagnosis, right? So it's not something which we expect you all to give causes of splenomegaly. We expect you all to give, okay, causes of splenomegaly in this time. Otherwise, we could have assessed that in your MCQs. Okay, causes of splenomegaly includes. Okay, now hepatomegaly plus fallow. Now, when there is fallow, okay, think about anemias. When there's hepatomegaly, you know things, right? So then hepatomegaly and anemia, okay, could be hereditary spherocytosis, thalassemia, even Wilson disease is a possibility here, hepatomegaly and fallow. But in Wilson, you will get mild tinge of jaundice also, right? So hepatomegaly plus fallow plus jaundice. Okay, rather than now hereditary spherocytosis can present without any active hemolysis. For you to see jaundice, but they will be having chronic. They will have chronic fallow, right? And thalassemia will not have significant jaundice, right? They will have just tinge of jaundice. But hepatomegaly, fallow and jaundice is very common in autoimmunohemolytic anemias and hereditary spherocytosis. You can say even Wilson's disease as well, because in Wilson you get Combs negative hemolytic anemia. Okay, isolated hepatomegaly plus splenomegaly. So very large liver and spleen, but no fallow, no jaundice. So that is very common in storage diseases, right? Storage. So this is not something easy. So that's why abdominal examination, you all will examine well, but you all will not score very well because you can't give proper differential diagnosis. Now, if you have everything like hepatomegaly is there, splenomegaly is there, jaundice is there, fallow is there. So any chronic liver disease, portal hypertension is a possibility. Like it could be Wilson's, biliary atresia, autoimmune hepatitis. Now, conditions like autoimmune hepatitis, you could have mentioned with hepatomegaly plus jaundice section as well. So I will put that also now here. tract. Okay, now this is the real thing in exam. Now probably this is a 4-month-old boy, and when you open the abdomen you could see a surgical scar. The name of this incision is called rooftop incision, and you can see pale stools nearby. So that means this is highly likely a case of biliary atresia who underwent Kasai procedure. It seems that the Kasai procedure is not successful now. That's why this child is still having pale stools. So how are you going to present? Okay, I examine this 6-month-old baby girl's abdomen. She seems to be well grown for her age, but I would like to take anthropometric measurements and plot it in a chart. She's deeply icteric and mildly pale. It's very important to say deep, mild. So these terms are important. She's afebrile to touch and has no palm erythema or peripheral edema suggestive of chronic liver disease. I can see a diaper in which pale color stools are evident, and the urine sample which is nearby the child shows dark colored urine. Her abdomen is distended and there is an abdominal scar across the midline suggestive of rooftop incision. The scar looks healthy. So always use short sentences. The abdomen is non-tender and moves with respiration. There's a 5 centimeter non-tender hepatomegaly with smooth surface and regular margins. The upper border of the liver is at 4th intercostal space. Stop. The spleen is palpable and which is around 3 finger breadths below the posterior margin. There are no free fluids in the abdomen. Auscultation of the abdomen did not reveal any renal or liver fluid. Her bowel sounds are known. My impression is that this child has got biliary atresia and for which she had undergone Kasai procedure. However, there is evidence to suggest that the procedure has not been successful since she has got persistent ecolic stools, jaundice and hepatomegaly. Further, her splenomegaly is possibly secondary to portal hypertension. So in this kind of a child, so the discussion will be, okay, how are you going to manage? So the management is supplementation of fat-soluble vitamins in high doses and long-term plan for a liver transplantation. You can talk about things like liver transplantation. Now these things are emerging in this country nowadays, right? Don't think that, okay, examiners might find fault with you mentioning, like, don't mention heart, lung transplantation like things. But liver transplantation, kidney transplantation, you can say. Okay, this is another case. When you open the abdomen, you found this scar and child looks mildly pale. So I examine this, just be examined. This 13-year-old girl's abdomen, she seems to be well grown for her age, but I would like to take anthropometric measurements and plot it in the chart. She's pale but has no jaundice, no deep jaundice. She has maxillary prominence and frontal boson. She is afebrile to touch and has no features of chronic liver disease. Her abdomen is distended and there is, now here do not need to mention abdomen moves with respiration, like, because we know this is a case of thalassemia, like, but liver disease, like, which can have ascending cholangitis like conditions, will need that kind of a statement. And there's an abdominal scar over the left side. The scar looks healthy. The abdomen is non-tender and moves with respiration. You can put it later, but not at the beginning. I could see iron chelation marks over periumbilical region. There's a 2 centimeter or 2 finger breadth, always better to say finger breadths, Non-tender hepatomegaly with smooth surface and regular margin. The upper border of the liver is at fourth intercostal space. The spleen is not palpable, obviously, because the surgical scar is for splenectomy. There are no fluids in the abdomen. Auscultation of the abdomen did not reveal any renal or liver behavior. Bowel sounds are normal. My impression is that this child has got transfusion-dependent anemia, and as a treatment modality, she had undergone splenectomy. So the likely transfusion-dependent anemia could be beta thalassemia major, right? So then the examiners will now up to this level you can score 75 marks, but another 25 you will need to answer certain questions at the discussion. Okay, I will give a small break, probably 1 minute or 2 minutes before I move into this. I need to drink something. Right, I'm just looking at some of your questions in the chat. Can we use building blocks instead of cubes? Yes, whatever it's something you can give large one. Should we have to ask make or tower cubes? Now that is not necessary because we asked to do that after 18 months now. So if you can see that the child could not turn pages one page at a time and child could not hold the crayon in a proper mature way. So now holding crayon like this is a 14 months like. So in that case, you know, no point going beyond that level, right? So that's why I try to minimize your syllabus. Can we give a toy for checking palmagrass instead of cube? Now, when you give toy, what will happen is you have to take that toy out and give another again a cube, right? We cubes තියෙන ඕන තරම් ඔය පොත් කඩවල. දැන් අද cubes ඉවර වෙද්දී දන්නේ කඩවල. Giving cubes essential rather than cube. Can we give toy like small one? No, I don't recommend you to give ball where you can't access the bag. Now these are standard techniques which I am telling you all over the world. This is how people practice developmental assessment station. Now, I don't think ball is a good option. You can give a ball, but again you will have to give a cube. Do we need to do distraction? No, I don't think you for distraction test you need I mean standard place or controlled environment should be there. I don't think exam setup is a good place for distraction test. So do we percuss the liver even if yes? Liver percussion of the liver is important even if the size of the liver is normal. Liver normal. You don't know liver normal size without percussing upper border of the liver. What you can say, even if we do not feel liver, do we have to percuss? Yes. After percussion only you know, okay, your liver is not shrunken. What is the correct way to palpate for liver spin in children? With fingertips or with radial border of the hand? My personal practice is radial border of the hand as in adults, right? But some says you can go for fingertips also. But I see lots of medical students push, right? When you try to do with fingertips, always be gentle, then this should not be a problem. Can there be hepatosplenomegaly together also? I think I have already answered that. In hepatomegaly or splenomegaly, do we have to measure the distance from the? Not necessarily. You can just measure with your fingerprints. So if there's a case of do we need to look for other complications? Yes, very good. If there's a case of thalassemia, if you can look for like goiters, maybe pubertal staging, so that's good, right? If possible, that's good. You can score more marks, right? It's like a case of cyanotic heart disease looking for evidence of hemiplegia. Right, now let's come to CNS. So CNS examination will be, I would say 75% of the time, lower limb examination. I have never come across upper limb examination in pediatrics in final MBBS exam. But for your medicines, you will have to do upper limb examination. Because of that, if it is a case of upper limb examination, then we will be giving probably around 14, 15, 16, almost like an adult. So other than lower limb examination, the next common thing would be facial nerve palsy, Bell's palsy. Just prepare for these two rather than thinking of all the possibilities under the sun. Right? Just narrow down your syllabus. Now 20% of your syllabus will be there in your 80% of cases. Right? So lower limb examination, that's the commonest command. So possibility is a hypertonic lower limbs. Lower limb tone is high. So high tone in lower limb could be due to spasticity or dystonia, basically extrapyramidal or pyramidal tract problems. Then the lower limbs could be flaccid. So it could be lower motor neuron type anything. It could be myopathy, neuromuscular junction disorder, or it could be neuropathy, that one. Maybe involving CP, also you can have flaccid lower limbs, right? And very importantly, sometimes lower limb examination may not be neurology in origin. Now even last end appointment also we gave a case of rickets, right? And in the command we mentioned, okay, inspect, start with inspection of the lower limb and then proceed. That's how we gave the command. So it may be a case of rickets, erythema nodosum, it may be a chest pain, right? So lower limb, what are you going to do? So inspection is important. Then the motor system is there, sensory is there, cerebellum is there. We usually don't expect you all to do sensory examination of the lower limb. It's time constraint. And the motor examination, 4 components are there: gait, tone, power, reflexes. And at the end of this, you can do limited number of cerebellar signs in the lower limb, like heel, sheet, chin test. Right, what are you going to inspect in your lower limbs? So the posture is important. Let's see whether this can be played. Can you all see this video? Okay, now can you see?
Yes, sir.
Yes, sir.
So the difference between frog leg and the normal legs, right? Now you can see this one, the one on my right side, has got flex knees, but the one on the other side is not having Don't. Right. So frog leg position. This calf hypertrophy. This is called champagne bottle leg high and high foot touch in Charcot Marie tooth. You will not get in your exam. Neurocutaneous stigmata are very important, like cafe always sports and all. Symmetry, and also sometimes muscle biopsy scars. Right, these are the inspections. Now, most of the time, when we want to give you a child with cerebral palsy, we will ask you to start with lower limb examination. But when you reach the patient, you know, okay, this child has got something more problems than in lower limbs, right? But in adult lower limb examination is different. So the problem will only be in lower limb. But in pediatric, as you enter the case, and you all will be scared to see these kind of children, right? Uh, so in that case, you need to know, okay, other than lower limb, you will have to do lots of other things in this case. So rather than wasting time only in lower limb, be prepared to quickly go through the whole nervous system, right? So in a case like this, you are not going to ask for gait. No point, you know. You all know now these two children will not be able to walk. But if it is not the case, better to start lower limb examination with gait. What is this gait? I have mentioned it. So it's waddling gait. This is a feature of proximal myopathy. Proximal myopathy. Most common proximal myopathy in children would be Duchenne muscular dystrophy. Okay, this is very important. You can see circumduction gait of right side, and the right side arm swinging is low, and then she use left hand more than the right hand, right? So that's hemiplegic gait. So usually antalgic gait is not given in neurology exam, but if you were asked to examine lower limb and if you find this, so that may be a case of rheumatological examination, which we don't expect you to do it in the exam. And this is something common. See the way she is coming. So you can appreciate that she has got lower limb spasticity. So she says bye. See you again. Right. So now I'm going to teach you all an important concept uh, of hypertonia. So, so hypertonia could be due to two reasons. One is spasticity, one is dystonia. So spasticity means something you have to demonstrate. Until you demonstrate it, you will not be able to tell child is hypertonic. But dystonia is something you can observe, right? If the child is like this, so child is dystonic. Uh, so in spasticity, reflexes are exaggerated, but in dystonia, reflexes are normal or maybe slightly exaggerated. So tone can be, I mean, the spasticity will not be changed during sleep, but dystonia is reduced during sleep. In spasticity, you get clonus, but in dystonia, clonus will not be there. And in spasticity, touching the patient will not exaggerate the tone, but in dystonia, once you touch the patient, it will exaggerate the dystonia. And the treatments are totally different in these two conditions. Because of that, it's important to appreciate these two conditions as two separate entities. So antispastic treatment like dantrolene sodium, botulinum toxins, those are baclofen, those are important in spasticity management. But in dystonia management, what is important is levodopa, co-caraldopa, co-beneldopa, that kind of things. But in our children with cerebral palsy, these two conditions commonly both things occur together in cerebral palsy. Especially in analyses done by lots of neurologists in this country, most children will have dystonia on top of spasticity. For medical students, seizures are almost always generalized tonic-clonic convulsions. For medical students, cerebral palsy is also spastic quadriplegic cerebral palsy. But think beyond that and try to find whether there's element of dystonia also. If you can see some abnormality in that child, definitely dystonia is there. So you can now see how many children with cerebral palsy you would have seen, but you would have not mentioned a word about dystonia, right? Okay, what is this? Is it dystonia or spasticity? Now you can see he's having these movements, right? Even without demonstrating anything, you can see child has got dystonia, right? So in an older child, lower limb tone, if hypertonia is there, it could be hypertonia, could be due to dystonia or spasticity. Most important thing is upper limb. So this is likely a case of cerebral palsy. And if lower limb tone is hypotonic and very floppy, I would say the next thing would be to examine the back. But even in a child with cerebral palsy, it's important to examine the back, but not at the expense of upper limbs, right? Even in a child with hypotonia in lower limbs, it's important to examine upper limbs, but the priority should be to examine back, right? Now, this is a $1 million question for you all when it comes to exam. How do we say power of a child in neurology exam? Now, for this, you should have examined 100 children for lower limb power to say what is normal. Now it's too late because when you all doing appointments, you didn't examine lower limb power when you get a child with asthma. Because that's not relevant. At thalassemia, you didn't examine lower limb neurology. But the idea behind doing all system examination is to know what is normal. And then only you will realize what is abnormal, right? So now I will give you tips only. Now, if you can see child has got active movements against gravity, that means child could lift limb, that is above 3, then you will have to just press forcefully and ask the child to lift against gravity. If you can, if you are getting a child who can do these commands, okay, you can say it's whether it's 4 or 5. But in small child against gravity, if you see, okay, that's 5, you can just apply pressure and just see whether the child is moving up or not. If you can see that, you can put it as grade 4, but if not, keep it at grade 3, right? So most of the time, power of children with neurological problems will be around grade 3 or grade 4, right? You will not get a child with 0 and 1 or 2 power. Sometimes you might get only flat movements. In that case, power may be 2, but 2, 3, 4 will be the area. So reflexes can be absent, can be reduced, or can be normal, or maybe increased. Now, if you do get absent reflexes, you have two differential diagnoses. One is whether there's a problem of the child or whether there's a problem of yourself. Even for me, I have that problem. Or whether I could not elicit reflexes or whether this child has got no reflexes, right? Because of that, take things, everything together, right? Now, lower limb power of 5 or 4 definitely should have reflexes, right? If you can't, if you could not elicit it, you can ask the child to do certain maneuvers like reinforcement, right? And so the knee-jerk uh, root, nerve root is L2 to L4, and ankle jerk is S1. Plantars can be going up till 1 year. Now this is another question. When you examine the lower limbs are hypotonic, but very minimal tap, you get very high reflexes. Okay, now when it comes to presentation, your mind has dual thoughts. In your textbooks, you have learned, okay, lower motor neuron lesions, hypertonia with exaggerated reflexes. Upper motor neuron lesions, hypertonia with exaggerated reflexes. But unfortunately, in the exam, for the first time, you are getting a patient with hypotonia with exaggerated reflex. Can that happen? Yes. It's very well described in children because in the period of evolving cerebral palsy, like the brain damage that's occurred at perinatal period, child is floppy in first year or so, then only these children will get spasticity. During the transition from hypotonia to hypertonia, that is common even in spinal injuries. First they will get hypotonia, flaccid, then they get hypertonia. During this transition, there will be a point where you will see exaggerated reflexes despite child is hypotonic. So cerebral palsy, there are different types. Mostly these are mixed types in Sri Lanka. So you will be asked to start lower limbs, but you know since beginning this is a case of cerebral palsy, right? But then how are you going to do? So start with lower limbs. If there's spasticity, examine upper limbs. If there's flaccidity, go for back. Then measure head circumference, then top to bottom. Without measuring head circumference or commenting head circumference, you will not be able to get a pass mark in case like cerebral palsy, right? So eye examination is important just to see whether there's squint. Oral hygiene is important, skin is important, respiratory system, abdominal system. These are very limited focus examinations on other systems. Now how are you going to present? So I performed lower limb neurological examination of this 5-year-old boy. He seems to be developmentally delayed compared to, you can start with that statement because that is the, or you can say the most striking feature of this child was he seems to be developmentally delayed. He is well kept and the growth appears to be average for his age, but I would like to objectively measure and protect in a chart. He has thin muscle mass and subcutaneous tissues of the lower limb because you were asked to examine lower limbs, no? Because of that, it's always important for you to present lower limbs in detail and then go for the other systems. There are contractures over both knee and ankle joints. I could see active anti-gravity movements, therefore his lower limb power is grade 3. His lower limbs are spastic with positive ankle clones. Lower limb reflexes are exaggerated with upward plant. Besides, he has got generalized dystonia as well. Right? His upper limbs are also spastic and has got exaggerated reflexes. He has microcephaly, but there was no obvious cranial nerve abnormalities. He is wearing diapers, which means he has no bladder bowel containers. In conclusion, I think that this child has got spastic quadriplegic cerebral palsy with some element of dystonia. So this will be this is how we are going to present. Okay, then the discussion will be, okay, what do you think the likely cause? Then we will ask, you can say, okay, hypoxic ischemic encephalopathy, that's a newborn problem. And neuronal migrational disorders means that's an antenatal problem. Inborn errors of metabolism, IEM, means it's a postnatal problem. So any of these problems can manifest like this. Now, if we say, okay, if this is not cerebral palsy, what else could this be? Now, I used to ask this question. If it is not cerebral palsy, this could be a case of neurodegenerative disorder. That is the only differential diagnosis you can say. Even at the time of presentation, you would have mentioned, okay, I think that this child has got a case of cerebral palsy, or it may be a case, other possibilities, this child might have got a neurodegenerative disorder, which I don't know the trajectory of the development. How are you going to manage? Always start with the term multidisciplinary, and then in the meantime think who are the people you are going to invite. Now this is the other most common case. Now when you examine lower limbs are flaccid. There may be reflexes or may not be. And back examination, you might not see these kind of lumps. All these children would have undergone the surgical correction. And it's very important, lower limb, back, head, and then upper limbs. But in spastic lower limbs, upper limbs, head, and then back. In spastic child, examination of the back just to see scoliosis is there or not for any scars. Then top to bottom, like fontanelle, dilated veins, palpate for VP shunt. So definitely these children would have had VP shunt, sunset sign for eyes, gaze palsy, chest palpate for the VP shunt, abdomen palpate for palpable masses because they will have neuropathic bladder, vesicoureteric reflux, and bilateral hydronephrosis. That's the importance of examining for bladder. And anus will have no tone, the platulus anus will be there. And some of them will have congenital talipes equinovarus. So I'm going to present. So I performed a neurological examination of this 5-year-old boy's lower limb. He is alert, active, and seems to be adequately grown for his age, but I would like to blah blah blah. The most striking abnormality I noted on this child was a large head with sunken eyes suggestive of hydrocephalus. That is, at a glance, you can just mention a broad statement. He has thin muscle mass and subcutaneous tissues of the lower limbs. Lower limb power is grade 3 since he has active anti-gravity movements. His both lower limbs are hypotonic and I could not elicit lower limb reflexes. Examination of the back revealed the heel scar at the lumbosacral region. He was on a diaper which suggests that the child is still incontinent. His upper limb neurology is normal. I could not feel for any palatable masses in the abdomen. I would like to measure his blood pressure. And I forgot now here after that you have to mention uh, examination. Okay, so examination of the head revealed a functioning knee patient because in the past there were reservoirs in these VP shunts where you can press it and empty it and see whether it's filling back. But nowadays, lots of different types of VP shunts are there. You will not be able to press it freely, and some of these shunts you are not allowed to press it because otherwise you will not be able to tell it. But you can just mention you fail the VP shunt. In conclusion, I think this child has got Arnold Chiari malformation type 2. So that is the condition where you get meningomyelocele plus hydrocephalus. So cranial nerve examination, most of the time it will be facial nerve examination. Prepare for that, where then you will be asked, okay, motor cranial nerves or upper cranial. Upper means 1 to 6, right? In that case, facial nerve might not come. Usual command will be motor cranial nerves. You will have to do in a way you do it in adults. But keep this in your mind, 99% of the time it will be Bell's palsy in children. Now cases like Weber syndrome, these lateral medullary syndromes, and these things are not there in pediatrics. So pediatricians are very poor at localizing the lesion in neurology, right? Medial, longitudinal, fasciculars and all, we are not that familiar. So most of the lesions in children are bilateral, not localizing. Right, facial nerve palsy, and it's important to know in upper motor neuron lesions, you get only mouth deviation, but in lower motor neuron lesion, you get forehead involvement as well. So in this kind of a thing, you can present, I have not put special thing for this. You can say, okay, I did I performed cranial nerve examination of this 5-year-old boy who was very cooperative during my examination. He seems to be adequately grown for his age, and I would like to measure his weight and anthropometry and plot it in a chart. The most striking abnormality which I noted during my examination was he has got mouth deviation onto the right side and he could not close his right eye or left eye, right? Then regarding third, fourth and sixth nerve examination, I could not find any abnormalities. He could have all full range of movements. And the trigeminal nerve examination did not reveal any abnormalities, including the preserved jaw jerk. And the cranial nerve examination showed absent movements in the orbicularis oculi and orbicularis oris on the one particular side, and the other side movements are normal. So therefore, highly likely that this child has got a lower motor neuron type facial nerve palsy. Therefore, I look for an etiology of this, and I could not find any ear abnormalities, any surgical scars over the parotid region. There were no features suggestive of Ramsay-Hunt syndrome, and I would like to assess his hearing as well, because sometimes this may be a case of um, uh, any tumor starting in the pons, right? Uh, so that kind of approach for facial nerve, but this is also very, very rare in pediatrics. So neurology cases in pediatrics, 99% of the time would be a case of cerebral palsy or meningomyelocele. So prepare for those two to score a distinction mark. That is what is called preparing for exams. So read the exam and prepare. You can't prepare for all cases. When you are trying to study, you will realize all the things. Right, I think that's the end. Okay, for the first time I saw this, so I thought to put it in the slide. So the Independence Day. And this is what is you have been expecting. So questions are warmly welcome for next 10 minutes. I think I would love to hear your voices. What happened to during last few weeks? And also make sure to send the feedback forms. Now this has been a problem because we have sent you all feedback forms after we did lectures, but only 1 or 2% or maybe 1 or 2 from the whole batch has responded to it. So this has become a problem because University Grant Commission wants all these feedbacks. They are not sure whether we are teaching well or not. Basically, that's why. Any questions? So if you ask to examine the abdomen, are we supposed to start from general? Yes. Start with general examination in abdomen cases. Or any other thing you can. Sir, did you do an APLS class? I'm going to do APLS class for 38 batch today at 3 o'clock. APLS means Advanced and Pediatric Lab. So at the beginning, when we take permission from mom, can we ask baby's age? Yes. I mean, not in the cases of developmental assessment. Could you please kindly upload this lecture? Wow. Okay, we'll see. I will do that when I get at least 100 feedbacks. That's the deal, right? After lower limb examination, is it necessary to get permission from the examiner to examine upper? No, no, no. No need. So you can say, because you are not robots, so you can say I went ahead with upper limb. So in the presentation you can say because child has got spastic lower limbs, I wanted to see whether the upper limbs are also spastic or not. So that's not a problem. So what happens if we miss a physical sign like splenomegaly, and if we present and did according to the other fine, how it all depends on how large the spleen was, one thing. And because it's sometimes you might miss a spleen in IMN spleen, typhoid spleen, easy to miss. It will not be a problem, but if you can give at least rational differential diagnosis, you will get a good score. In diplegic CP, how do we proceed? The same way. So any CP, I think the way I have mentioned, like even in diplegic CP, the marked abnormal will be on the lower limbs. Upper limbs will be fairly spared and the IQ will be very good. And they will not have generalized dystonia like things. In quadriplegic CP, you get this dystonic type picture. So when we ask to examine skin rash, should we elicit blanch? Yes. Should we elicit crisis crisscross appearance? So crisscross means scissoring. Yeah, sometimes if it is a small baby, like maybe around 1 year, like lower limb examination. Now lower limbs are spastic. When you look at the upper limbs, they are not that spastic. Head circumference is also normal. Then better to lift the child up and just see scissoring of lower limbs. The crisscross is not the best term, but Percussion for palpable abdomen, should we do that too? In both? No. Well, yeah. I mean, it. If you have time, if you feel child has got fecal masses, like, you can do that, but don't waste time. So in a CVS case, is it okay to ask the child to sit twice to examine subscapular area? Yes, fine. But always, if you can do it in one go, that's the nice way, right? But no harm. Can you briefly mention the what are the things we should do in case of bow legs? Okay, yeah, that's important. Bow legs could be due to two reasons. One is rickets. One is metaphyseal dysplasia, right? If bow legs are there, your task would be to look for evidence of rickets in other places. So the other places would be rickety rosary. For that, you have to ask the child to keep hands like this, and then wrist whitening, frontal bossing, and measure OFC. Then the next task is to look for, okay, why these rickets? Is it nutritional? Is it liver? Is it renal? So in that case, the third component, so first you identify the rickets, then you look for features of rickets in elsewhere. And the third component would be whether the child has got CKD, whether the child has got liver disease, which I am pretty sure they will not have. Then just commenting it. Okay, I look for evidence of rickets in other side, but I could not find any frontal bossing, rickety rosary or wrist widening. And the head circumference is this. And then I look for possible causes of rickets, like features of chronic kidney disease and liver disease, but I could not find any features of chronic liver disease such as jaundice, hepatomegaly, palmerythema, spine like, and no features of chronic renal failure as well, looking at the child, where child is not paying. And then the examiner will ask, okay, what are the possible causes? It may be rickets, it may be metaphyseal dysplasia. Then how are you going to differentiate? I would like to do a wrist X-ray and the X-ray of the bone. So the lower limb. So even in metaphyseal dysplasia, you will have abnormal bone abnormalities. Then yeah, so then we will ask, then how I going to differentiate? Then the biochemistry. So high ALP is a feature of rickets, normal ALP is a feature of metaphyseal dysplasia. Sole and knee joints we will not give you, it will be a long case, right? So in one infant or 1 age, yes. No, always. So the question is, one infant or 1-year-old child, how we assess reflex. So any age you should be able to use the tendon hammer. No finger, right? Or you can just keep your finger on top of the knee joint if the child. Now don't try to elicit reflexes in probably 1 month, less than 1 month, don't do. But even in 3 months, with children with this thing, spinal muscular atrophy, Wernicke-Hoffmann, will come, will present around 3-4 months. So you should be able to do that. So what are the grave mistakes commonly done by students? So grave mistakes, there's nothing like that. So most of the medical, no one is going to hit children. So that's good, at least. But in certain parts of the world, candidates have threatened patients. So that is not seen here. grave mistakes wise, I don't think you will be failed. You will be marked down for one particular thing. So it will always be collective thing. So the grave mistakes are multifactorial. I can't say. Oh, so this is not about today's class. During the selection of the sequence of medical for each group, if take it as in order of MD number, some of us have to go at first and some of us have to go in last. There are disadvantages and advantages going first and last. But so if taken according to MD number, some one at first or last and all. So what do you all think? Those who did long cases first will be given short cases last. Those who did long cases last will be given opportunity to do short cases first. What do you think? Rickety rosary and rackety rosary same. Anyway, I don't know. I will not be an examiner for your exam because I am not that mature according to the system. So anyway, I'll be around the exam. Anyway, I will take this point and because I can show this to Naira madam, and I also feel because when I was a medical student, I always get the chance last. I was also not that happy those days. Oh, this is the last slide. Shuffle at the morning and then decide the sequence. Is that possible? That's good, sir. If they will be like that. So will Prof. Sujiva come to the exam? Yes. But he is a very good examiner. Right, at the exam. The problem will be your sympathetic overactivity. So I don't know. I don't think he will come. So can we get infantile spasm as long case? Yes. So infantile spasm, if you have, yes, we will give it. But very difficult to find. So seizures. So just think about child with seizures. I think that's it. I have to do a class for registrars. So all the very best, and if you can spend probably 1 or 2 minutes to send feedbacks. I don't need good feedbacks. I need genuine feedbacks, right? And then after that, I will upload this. That's the deal. So all the very best and see you all on probably next Monday. Oh yeah, Monday. Right?
Thank you, sir.
Okay. Okay, this is.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
This is the slide.